Good afternoon everyone. So today I would like to talk to you about our project and an initiative that we have implemented within our ICU, which has demonstrated that end-of-life care and nursing satisfaction is enhanced by the implementation of a clinical information system based protocol. So I'll just explain that the clinical information system, or CIS, refers to our bedside computers, which we use for our patient observations and documentation. So we implemented a computer-based protocol to guide the care that we provide for our dying patients. And this has been the work of the Adult Intensive Care Service Empathy Project team, and I'd like to acknowledge the contribution from all of the staff involved. This is an overview of what I'll speak about in my presentation. I'm going to talk about why end-of-life care is so important to us. I'll explain what the Empathy Project is and its aims, and I will then outline the objectives of implementing an end-of-life protocol, explain the methods used and our findings. For human beings, life is meaningful because it is a story, and in stories, endings matter. This is a quote from Atul Gawande's book called Being Mortal, and these words really stuck with me because I truly believe that caring for dying patients is such an important part of what we do. And our team feels very passionately about getting this right. Among all of the advanced technologies in ICU is a person, an individual who has a life story, and the way that we care for them has such a powerful impact on everyone involved in receiving and delivering that care. So as you know, ICU is a particularly curative-focused acute care setting. So at times we experience many challenges as a team when it comes to managing these patients. Having said that, we're also in the very privileged position to be able to spend plenty of time with patients and families. So providing technically excellent, compassionate care to these patients and their families is an important aspect of ICU management. Upholding the patient's comfort and dignity while supporting the family and staff are key considerations. So we asked the question, how can we deliver optimal care at the end of life? And from there we started the Empathy Project. We have a medical lead, Associate Professor Dr. Nikki Blackwell, our CNC Wendy Bennett, and 3 clinical nurses who share 1 FTE position. And we also have social work support. Empathy is an acronym for End-of-Life Management Planning and the Hard Yards. The project has implemented many initiatives within the Prince Charles ICU, focusing on management of our end-of-life and long-term ICU patients also. The project work is supported by current guidelines from ANZICS and the National Consensus Statement on the Essential Elements for Safe and High-Quality End-of-Life Care from the Australian Commission on Safety and Quality in Healthcare. Both documents provide a useful framework for the multidisciplinary team providing end-of-life care and help support the principles of a good death. A couple of the standards relevant to this presentation are number 6, leadership and governance, where policies and systems are in place for end-of-life care, and number 9, evaluation and feedback, where the quality of end-of-life care is measured and improved. We recognised that we had no real ICU-specific guidelines in our workplace to support the care of our dying patients. Most of the time the care we delivered was adequate, but we had no consistent processes for the team to follow and no way of demonstrating that we actually were providing quality care. This had the potential to be very confusing and frustrating for the team and made the patient quite vulnerable. We identified the need and set the objective to formalise and normalise our processes for caring for this patient group. One of the advantages of utilising an electronic documentation system includes the availability of organised tabs for ease of access to information that is clear, consistent and timely. So we wanted to use the CIS as a central place for documentation and communication for the team, led by Nursing Initiative. We then developed a tool to be used for this purpose. We evaluated the tool and whether symptoms were documented and managed. So the methods we used were quite simple. A CIS-based documentation and decision support tool for end-of-life care was developed and implemented in consultation with key stakeholders. We started to use the tool once there had been a family meeting and a decision was made to move to comfort care. The The bedside RN then initiated the tool for their patient. A two-pronged audit process was developed which evaluated, first of all, the delivery of care as per the documentation on SIS, and secondly, we included social work bereavement follow-up with families. So this allowed us to evaluate the family's perception of the care and gathered their feedback, which of course is of the utmost importance and very valuable. The audit results were presented at our monthly quality and safety meetings. Our nursing staff were surveyed to explore nursing satisfaction, feelings and attitudes around end-of-life care in the ICU. Audit and survey data was compared pre and post comprehensive staff education and training, which supported the use of the tool. So this is a screenshot of the end-of-life tab on SIS. This was the dedicated area for documentation of care planning, symptoms and order sets. So the coloured tabs across the top here offer a systems approach to documentation, and the end-of-life tab was on the far right-hand side there. So up the top here we've got standing orders for symptom control medications. We've got links to ARP forms, we've got links to an end-of-life care checklist, and then we've got symptom control documentation down the side here, which is documented at least hourly until it's managed. So this is the only place where observations are required after commencing comfort care. We no longer use the vital signs cardiorespiratory tabs. And this really helps shift the mindset of the bedside nurse away from the acute care monitoring that we're used to in ICU and now towards providing compassionate comfort care. This checklist is available within the tool to prompt care planning. It covers items that should be considered or discussed at the end-of-life family meetings. It then prompts the team to consider rationalising the interventions that are needed now that there's been a shift in the goal of care. So, for example, have unnecessary interventions and observations been discontinued, such as blood sugar monitoring, x-rays, and have non-essential medications been ceased, such as antibiotics, and including enteral fees if suitable. The checklist also covers communication and asks, for example, if it's appropriate, has the Indigenous Liaison Officer been contacted, palliative care team, pastoral support, communication within the wider team. So our data was collected for an 18-month period and we audited 162 patients. We did not expect the tool to be used if there was a very short admission time, for example, less than 2 hours. Also, we did not include patients where curative care was in place at the time of death, so for example during an arrest. In these circumstances it's a clinical emergency and the team has not elected to initiate comfort cares. Our initial data showed suboptimal uptake of the end-of-life tool, and as a result of this we invested more time in extensive education and training, which was rolled out for nursing staff. Compliance and documentation with the tool then improved from 55 to 89%. So education was a really important part of implementation to enable effective use of the tool. It's clear that the tool alone was not effective without the initiative and knowledge held by the bedside nurse. Of course, pain management is a critical aspect of quality end-of-life care. The results from the audit tool evaluating documentation on SIS, for example, showed a marked improvement in the documentation and management of pain following staff education from 56 to 89%. For the purpose of this presentation, we've used pain as a quality indicator and have demonstrated through the use of the tool that we have documented adequate pain management. We can see that protocolisation of the care processes has resulted in the expedited management of patient symptoms and supported bedside nursing staff. Other symptoms that we assess and document include anxiety and fear, delirium, nausea, dyspnea, myoclonus, secretions, restlessness, and importantly, family distress. A very important aspect of this study was the nursing staff perceptions. So did the SIS-based end-of-life tool enhance nursing satisfaction around the delivery of end-of-life care? So a before and after questionnaire was used and the results did show a marked improvement in the number of staff who felt confident or very confident that they could meaningfully contribute to end-of-life care. The results indicated an increase from 33 to 56% of nursing staff now feeling confident or very confident. tool helps support and empower bedside nursing staff through the care planning process and enables escalation of questions and concerns to the team in a timely manner. I'd like to note that the data presented here in relation to pain documentation and nursing satisfaction is statistically significant. Our ICU social workers have always provided bereavement support to families, and if they felt it was appropriate, they would gather feedback by asking a few questions in conversation. This process continued through our trial, and the feedback remained positive post-implementation of the end-of-life tool. I'd like to tell you a bit about the gentleman in this photo. So we had learned through his time in ICU that he came from a family of winemakers who made their own sparkling wine. So you'll see that there's I don't know if you can see, but there's a wine glass placed in his hand there, and what we did was we swabbed his mouth with the taste of the wine, and when it was time to say goodbye, his family spent time toasting his life and sharing stories and, celebrating the man that they called the heart and soul of their family. So that was a way that we were able to really personalise the care at end of life, and the feedback was that they appreciated how we were able to make such a sad time so meaningful and special to them. Through our feedback processes through families, they always reported that they were satisfied with the care. They were routinely asked how we could enhance our care delivery, and if they had suggestions, this was used as part of our continuous quality improvement. From our work, we've been able to make the following conclusions. A SIS-based end-of-life tool has been developed and used in ICU that is effective in enhancing end-of-life care delivery. It has allowed protocolisation of the end-of-life care process, improved documentation and expedited management of patient symptoms. With comprehensive education and training, the tool has demonstrated the delivery of optimal end-of-life care and hence improved nursing staff satisfaction in the ICU. This tool can be adapted for other workplaces, and just as the principles of the Empathy Project can be also. I'd like to just touch on the future of the Empathy Project. We've achieved a lot in the last 2 years, and we plan to continue developing initiatives supporting our end-of-life and long-term patients. Some of our plans for the future include supporting staff education around patient advocacy and communication, particularly with regards to difficult conversations. We hope to implement multidisciplinary case conferences for our complex and long-term ICU patients. We are prioritising individualised care in consultation with patients and families. We recognise the importance of addressing staff emotional wellbeing and moral distress in the ICU. Compassionate care of staff is essential to combating the workplace hazard of compassion fatigue and optimising patient care. We are currently trialling GPS ICU, which stands for Guided Peer Support, and are receiving excellent feedback. We continue to promote delirium prevention, assessment and management. Just some take-home messages. Formalising processes helps empower nurses to provide quality end-of-life care. Staff education is key. It is our privilege and responsibility to provide technically excellent, compassionate end-of-life care for our patients and families. Endings matter. There's my contact details. Thank you very much.